Hello and welcome to the module on pharmacogenomics in oncology. I am Dr. Christine Walko. I'm an associate member in the Department of Individualized Cancer Management, and I am the Precision Medicine team lead at Moffitt Cancer Center in Tampa, Florida. This presentation is part of the ASHP BCOP Pharmacy Specialty Review course, which is designed for pharmacists seeking to obtain recertification credit or update their knowledge and skills in preparation for board certification. The activity is designed to be interactive with questions posed to you at several points. I will pause to allow you time to consider how you would answer the questions. You may wish to write down your answer and the correct response in your handout. This specific pharmacogenomic course was added several years ago and continues to expand based on the growing role of genomics in the management of cancers. The specific material in this module is based on Domain 1 of the BCOP course outline. I have no relevant disclosures for this activity. The learning objectives for this module are listed here. The purpose of this module is not to delve into genomic basics and terminology, however. I have an excellent review cited in the handout if you would like to review these concepts. This module will cover a variety of clinically relevant genomic concepts, as well as companion diagnostics and tumor-agnostic drug approvals. So why has genomics really revolutionized oncology? Well, we know that genetic alterations and molecular pathways are involved in tumor development, survival, and progression in metastases. We have the technology now and can actually interrogate why did a healthy cell become a cancer cell? What genetic mutations and alterations occurred? What pathways got turned on? What pathways got turned off? And then we now have a growing list of targeted anti-cancer drugs that are available commercially or in clinical trials. And this list continues to grow every month. So here is our first audience response question. We have a patient BT who is a 62-year-old man with metastatic castration-resistant prostate cancer. A recent tumor biopsy is sent for next-generation sequencing, or NGS, and is notable for a splice variant in the androgen receptor known as ARV7. Men with prostate cancer who were treated with the hormonal agent enzalutamide had lower PSA response rates and overall survival if their tumors were found to harbor this ARV7 splice variant. However, it is not known whether patients with this splice variant have poorer overall outcomes compared with patients without the variant, regardless of therapy. So based on this information, how would you classify the ARV7 variant? What type of biomarker would it be classified as? Would ARV7 be classified as a prognostic-only biomarker, a predictive-only biomarker, both prognostic and predictive, or neither prognostic nor predictive? So ARV7 would be classified as a predictive-only biomarker. As we will soon discuss, prognostic variants provide information outcomes independent of treatment, and the question states this information is not known. However, predictive biomarkers provide us information about response to specific therapies, in this case, predicting resistance to enzalutamide. So ARV7 would be classified as a predictive-only biomarker. So we use genetic information from different sources to make decisions for our oncology patients. This includes both alterations found in the tumor, also known as somatic alterations, as well as those found in healthy cells, also called the germline. So tumor genetic alterations are acquired genetic variations that ultimately provide information to guide treatment decisions and help determine who will respond to therapies. The germline alterations include both inherited genetic alterations, such as BRCA1 and BRCA2, that we know predispose patients to developing breast cancer as well as many other cancers. Pharmacists may be a little bit less involved, aware of these, but less involved because this is where our genetic counseling colleagues and our clinical geneticists often will work with these patients. Where pharmacists are involved is our genetic alterations in genes involved with drug metabolism, drug disposition, so basically our pharmacokinetic, our pharmacodynamic genes, and these are predictors of drug exposure and toxicity. The Clinical Pharmacogenomics Implementation Consortium, or CPIC guidelines, are an excellent reference for this information. So the CPIC recommendations, as I said, provide an excellent resource for how to adjust certain drugs based on germline pharmacogenomic alterations that are involved in the drug's pharmacokinetics or pharmacodynamics. Many of these are going to be discussed in their associated tumor modules. For example, TPMT will be in the acute leukemia module. And I would refer you to the handout that discusses these in a little bit more detail. Genetic variants can provide us different types of information to guide therapy, as we discussed in the first audience response question. We have both prognostic variants and predictive variants. Prognostic variants provide us information about cancer outcomes independent of treatment. They really represent the underlying biology of the tumor. One example is Notch1 alteration in CLL that, if seen, is associated with shorter progression-free survival and a higher rate of development of Richter's syndrome. For predictive variants, which is probably what we are most often working with, these provide information about the response to a specific treatment. So a classic example is an active EGFR mutation seen in a non-small cell lung cancer, which is going to predict increased response to EGFR inhibitors like erlotinib and gefitinib and osimertinib. So some biomarkers can also be both prognostic and predictive if they predict both outcomes as well as response to therapy, such as in the case with TP53 and CLL, which will be discussed in that module specifically. Genomic testing is really becoming standard in more and more cancer types. We use it to ask prognostic questions, especially in malignant hematology, and this will really come out in the malignant hematology modules on CLL, acute leukemia, chronic leukemia, and those disease states. We also obviously use it a lot for predictive questions. And the place in therapy continues to grow with new drug approvals that are not only in the advanced setting, but are now moving into the earlier stages in adjuvant setting. There are several examples of stage 3 melanoma patients. We want to assess BRAF because there are BRAF MEK inhibitors that are approved in that setting. Osimertinib is now has shown benefit in the adjuvant setting for patients with localized non-small cell lung cancer, and that will be discussed in more detail in that module. So we use genetic testing to help answer predictive questions as part of standard of care. We also use it in patients that may have a less common tumor or a cancer of unknown primary, where we may not have a lot of additional standard treatment options. Certainly patients with advanced disease who may have progressed through multiple options have or we commonly use it in. And then also, and thankfully a growing population, is in clinical trial enrollment, especially for clinical trials for which specific genetic biomarkers are part of the inclusion criteria. So ultimately, what we really want to get from these genetic mutation profiles is a genetic alteration a driver or a passenger mutation? And ultimately, you really cannot definitively assess this without additional investigative interrogation. However, driver mutations are the mutations that confer a selective growth advantage. These are the mutations that, as I said before, why did a healthy cell become a cancer cell? These are your driver mutations that are starting that process of oncogenesis, and then as they pick up additional mutations, you continue to have the growth of cancer. They can generally be classified into 12 different signaling pathways that regulate cell fate, survival, and genome maintenance. So these include our tumor suppressor genes, TP53, RB1, as well as our oncogenes, common ones including BRAF, EGFR, FGFR, KRAS, MET, PIK3CA. Inactivating mutations are what we typically will see for tumor suppressor genes, where these being the brakes on the cell get turned off by frameshift mutations, truncating mutations, whereas oncogenes will get turned on, often by missense mutations or fusions, other alterations such as that. Obviously, there's exceptions to this, but in general, you're going to have a tumor suppressor gene being turned off, an oncogene being turned on. And these are most clinically relevant when assessing our genetic tumor results. Passenger mutations, by definition, do not have an effect on a cell's growth advantage, and they're less clinically relevant. However, you can always determine a passenger mutation just by looking at a mutation. For example, BRCA2 may be a driver in a breast cancer. However, in a MSI high colorectal cancer, that has a lot of different genetic mutations, we may see a BRCA2 mutation as one of those 100 and some different mutations being reported, but it may not be the specific driver of the cancer. So these are things that, again, you need to rely on the literature available to help determine, is it a driver versus is it a passenger. So this brings us to patient case number 2. We have BF, who is a 41-year-old male with newly diagnosed glioblastoma who is being screened for an anti-EGFR therapy study. The medical team needs to test the tumor for all oncogenic mutations in EGFR, so the whole gene. The institution's in-house next-generation sequencing test assesses only the intracellular portion of the EGFR gene. So our question is this NGS test appropriate for BF's tumor? Yes, this is a hotspot NGS test that will cover the area of interest, which is we're looking at the whole EGFR gene. Yes, this is a whole exome test that will cover the area of interest. No, this is a hotspot NGS test that will not cover the area of interest. No, this is a whole genome test that will not cover the EGFR gene with enough number of reads. So this is an example of a hotspot test that will not cover the area of interest. Our goal is to test for all oncogenic mutations in EGFR for this patient to enroll on this clinical study. The assay states that it only assesses the intracellular EGFR mutations. These are the most common ones that are altered in non-small cell lung cancer, whereas we can actually see intra and extracellular mutations that are more common in glioblastomas and other types of primary brain tumors. So if we want to assess everything, this hotspot assay that will only look at the intracellular mutations is not going to be broad enough for what we need. You can analyze the genome utilizing many different methods and at different depths of coverage. As a reminder, DNA is transcribed into RNA, which is then translated into proteins and onto metabolites. We can assess each one of these utilizing genomics, transcriptomics, which are the most common methods that you will see in clinical practice. As a note, assessing RNA for fusions is actually much more optimal than utilizing DNA because you can see a fusion in the DNA that doesn't always get transcribed into the RNA. Proteomics, metabolomics, and epigenomics are additional sequencing technologies that are currently being investigated in clinical practice, and I expect and certainly hope that we'll see more of them moving into the clinical realm soon. The most common way that we analyze DNA and RNA is through next-generation sequencing because it can detect multiple types of genetic alterations. It has improved sensitivity and scalability and decreased costs compared to older methods. So as I said, you can analyze the genome using a lot of different methods and at a lot of different depths of coverage. As you go broader, you generally will lose a level of depth. So whenever we kind of look at the different hotspot versus whole exome versus whole genome, we look at how many genes are being tested and then what is the depth of coverage that each of those areas are being covered at. So for hotspot testing, we're sequencing only the genes and areas of interest. This may miss alterations outside of the targeted region. So for example, in our prior question, we wanted to look at the whole EGFR gene, and the assay that we had was only going to look at the mutations on the intracellular part of EGFR and not the extracellular. So it may miss ones that are there. Sometimes we'll see this with a very focused KRAS hotspot test that may not always get some of the less common activating KRAS mutations, which can be really important for treating cancers like colon cancer. It does allow for more sequencing reads, so a deeper coverage, and these do have a lower cost. Whole exome sequencing sequences all of the protein coding genes in the genome. It contains about 85% of the known disease-related variants, and it's more cost-effective than whole genome sequencing with much more manageable data output. So that's the other thing to consider with this, is the amount of data that you're getting back, because there's a lot of genes in whole exome sequencing that may fall under the variants of unknown significance category, where we know they may be involved in an oncogenic process, but we don't have as much definitive data to be able to say that. Now, whole genome sequencing sequences all the variants in the whole genome. Low coverage of all areas is typical. So there is a higher chance of missing an alteration if you specifically want to interrogate a certain gene. Larger data storage requirements also exist, and you really need some bioinformatic collaboration to manage the amount of data that you're going to get from this whole genome sequencing. Currently, most clinical assays fall between the hotspot and the whole exome, doing about 500 or so genes. We do have more clinical assays kind of moving towards the whole exome, but in general, true whole exome and whole genome sequencing are limited more to the research setting. Like I said, I think we're getting closer to certain ones being in the clinical setting, but again, our knowledge of directing drug therapy is still based on the specific alterations and the literature supporting their role in oncogenesis. So this will continue to evolve. This brings us to our third patient case. So we have VB, who is a 48-year-old female with non-small cell lung cancer found to have the EGFR L858R activating mutation. She has a metastatic disease involving her liver and adrenal gland. She was initially treated with erlotinib and had a good response for about 8 months. She now is found to have progression of her existing lesions, a new lesion in her brain, and in her pelvic bone. The team wishes to assess for the presence of resistance mutations to guide their next line of therapy. So they're considering using a cell-free DNA, a tumor cell-free DNA assay. So these are often called liquid biopsies. Is this appropriate for this patient? No, because she has pretreated advanced disease. No, because cell-free DNA assays are not yet available in standard clinical practice. Yes, because she has progressive disease in several metastatic sites. Or yes, because she has a new brain lesion. So our best answer is yes, because she has progressive disease and several metastatic sites. Cell-free DNA assays are helpful for assessing the heterogeneous genomic profile that may exist across cancer sites and are most helpful when there is more advanced progressive disease. When you have very limited disease or a patient is responding well to treatment, you may get a negative, or there won't be as much circulating cell-free DNA, and we'll talk about that in a few slides. So cell-free DNA assays are commercially available and are being utilized regularly in clinical practice. In terms of answer D, the brain lesion, if she had brain-only disease or a situation like a glioblastoma, primary brain tumor, the correlation between circulating tumor cell-free DNA and the alterations found in that primary brain lesion only correlate about 50%. However, something to keep an eye on is that we are looking at cell-free DNA in the cerebrospinal fluid, or CSF assays. And as that continues to develop, we may be able to interrogate CSF in the future to look for circulating cell-free DNA for primary gliomas, as well as instances where there's brain involvement. This is not currently yet in clinical practice, however. So as we talk about cell-free DNA, we have to start first with our gold standard, which is the tumor. So generally, tissue is the issue. Getting tumor and making a histologic diagnosis for solid tumors, as well as sending that tumor for genetic analysis, is kind of the gold standard. However, getting pieces of the tumor for biopsy may require invasive surgery. And this could be much more difficult in certain tumor types. Getting a lung sample is certainly going to be much more difficult than getting a melanoma, cutaneous melanoma sample that may be on the skin. Additionally, sometimes preparation of certain tissues, especially bone, where they have to do a decalcification process, can make genetic analysis challenging. This can destabilize the RNA, especially, making that more difficult to get a good quality assessment. Additionally, there's tumor heterogeneity concerns. You may have a primary tumor in the lung, but involvement in other sites like the bone, the liver, the adrenal gland. And so as the tumor evolves, it can pick up additional mutations. And if you're only assessing the tumor coming from the lung, and the adrenal gland is the one that's currently progressing, then there may be additional resistant mutations driving that progression that we may not be assessing if we're only looking at the primary tumor. Numerous commercial assays are available, plus many cancer centers certainly have their own internal NGS testing platforms, and I actually have a list of many of the common ones in the handout. So cell-free DNA assays are especially useful when tissue biopsies are not always feasible, or if we really want to look at if a patient has multiple sites of disease that some may be progressing, some may not be. You want to get a kind of overview of what are all of the genetic alterations that are kind of driving this whole process. So cell-free DNA is basically small fragments of DNA. So think of like chopped up DNA, kind of like Legos, little pieces of Legos that are shed off by the tumor as it grows or dies. The majority of cell-free DNA in the plasma is normal germline DNA. So an assay that is looking for tumor cell-free DNA is going to have very high specificity, and it's going to have to reliably be able to detect tumor cell-free DNA at very low levels. If you've looked at some of these assays, you can see that they go down oftentimes to 0.05% of the cell-free DNA, so you really need a very high specificity. What cell-free DNA assays do allow us to do is look at serial monitoring over time to assess resistant mutations and changes in allele frequencies. So if you kind of had a subclone of a certain gene that then over time evolves to be a major driver, that may help with directing certain treatment based on what the genetic mutation may be. As I said, it may better represent tumor heterogeneity. Patients who are currently responding to treatment, as I said, may have a false negative result because it's relying on cells turning over. And so if you have a very low disease burden, you may have a localized breast mass and no other site of disease, or you have a patient who is responding really well to treatment and has a partial response or a complete response, who may have no circulating or tumor cell-free DNA, or it may be below the sensitivity of the assay. So the best concordance between cell-free DNA and the primary tumor sites are based on a higher number of metastatic sites, lower albumin, and a higher number of prior therapies. So basically, your more advanced patients who are progressing on therapy. Ultimately, with any of these assays, what we want to find are actionable driver mutations. And so clinical actionability can really fall under benefit or resistance to a particular therapy. Sometimes we may have an FDA-approved therapy in the patient's tumor type, or we have an FDA-approved therapy in another tumor type that we may be able to utilize that data to get an off-label therapy. And then certainly clinical trials. A genetic alteration may match a patient for a clinical trial, or a trial that is assessing a novel agent based on, that may be very reasonable based on the molecular biology. We also do look for genetic alterations that provide diagnostic or prognostic information. There are certain tumor types, for example, in sarcomas, where a specific genetic fusion is very diagnostic of a particular sarcoma. In a research initiative that I was involved in, we actually did have some diagnoses change based on the genetics. So that is certainly very valuable. And then additionally, germline alterations that we see can inform disease risks. So if we see hereditary genes involved with hereditary cancers, as well as our pharmacokinetic, pharmacodynamic involved genes that we talked about previously with the CPIC guidelines. So for all of these different levels of clinical actionability, our recommendations are really only as good as the available data that supports it. Ideally, the type of supporting data we would want is a comparative trial with biomarker selection or stratification in preferably the patient's tumor type or a different tumor type. For some of the more common gene alterations, we do have this information. However, for the less common ones or less common tumor types, we're often looking at retrospective cohort or case control trials. Sometimes even a case study or a case series may be what we need, just because the genetic alteration itself is rare, or the tumor type is less common, or both can be occurring. And then sometimes, again, preclinical data can be helpful, perhaps in stratifying treatment options, though each clinical team will really decide the level of supporting data that they are comfortable with offering to patients. And patients also need to be involved in that discussion of understanding the level of data that is supporting an off-label recommendation, if that's the case. So one other topic to mention that is covered in more detail in the handout is the challenges with germline alterations. So cancer cells do evolve from healthy cells, and so gene mutations that are found in the healthy cells can be seen in the tumor as well. So sometimes, like with our BRCA1, BRCA2, if we see it in the germline, we see it in the tumor, this can be really important for directing treatment. But oftentimes, we want to focus on just what is specifically driving the tumor. So if the tumor is analyzed with matched normal tissue, you can subtract out the alterations that are found in the normal tissue. If anyone works with the Memorial Sloan Kettering MSK Impact, they will do this, as will some of the commercial labs as well. If normal tissue is not analyzed, it is more difficult to separate. Sometimes allele frequencies, if we see an allele frequency of a genetic mutation of 50% or 100%, this could indicate a germline alteration. However, you can't 100% rely on that, because it also depends on the cellularity of the tumor. We do use several different available databases. I have Exact and ClinVar listed here, and there is a more complete there's more complete information in the handout about resources to help determine germline versus somatic. Finally, the American College of Medical Genetics, ACMG, has recommendations regarding incidental findings. So if you do tumor genetic testing and there is a genetic alteration in like a BRCA1 or one of the other many genes that is associated with a common hereditary cancer syndrome, there are specific recommendations for referral for germline testing in those situations, and working very closely with a genetic counseling and medical genetics team is really essential whenever you're doing interpretation of somatic genetic alterations. They are part of our weekly tumor board, and an invaluable resource. And I do have my Calico Kitty on here whenever I talk about germline challenges because Calico Kitties are a great illustration of that, as well as you can see that she is sporting thumbs, which is a very, very obvious germline mutation phenotype. So now we're going to move into discussing some of the biomarkers that are used to guide cancer treatment. So these broadly include both companion and complementary diagnostics. A companion diagnostic is an in vitro diagnostic test that provides information essential for the safe and effective use of the associated drug. And this is what we'll be focused on talking about. So examples of this include several of the PD-L1 assays that I'm going to go over next for patients who are going to be getting immune checkpoint inhibitors such as pembrolizumab. Additionally, the assay Foundation 1 CDX, the CDX actually stands for companion diagnostic, is an approved companion diagnostic for numerous targeted therapies. You can refer to the handout for a list of what those are. Complementary diagnostics, I think we see a little bit less in practice. They improve the risk-benefit ratio of a specific drug, but they do not restrict access to the drug based on the presence of a biomarker. For example, there is actually a PD-L1 test for Nivolumab for patients with melanoma that may help guide when to use a single agent versus combination therapy. However, it is not required for the use of Nivolumab. So, seen less in practice than our companion diagnostics where it's required for the use of the drug. So starting with our PD-L1 companion diagnostics, each immune checkpoint inhibitor has their own PD-L1 companion diagnostic. So the specific PD-L1 test depends on the drug and it depends on the tumor type. There's a more complete list that's available in the handout, though these approvals are evolving, so I would refer to each package insert for the most updated data. In terms of pembrolizumab, we have both the TPS, which is the tumor proportion score, and the CPS, which is the combined positive score. The TPS score measures the percent of viable tumor cells showing partial or complete membrane staining of any intensity. And it is the companion diagnostic for first-line and later-line therapy for non-small cell lung cancer as a single agent. I have an example of what a TPS score may look like coming back from a testing company. The CPS score, which is used for the pembrolizumab approvals outside of lung cancer, measures the number of PD-L1 staining cells, so this includes tumor cells, lymphocytes, and macrophages, compared to the total number of viable tumor cells. So this number may actually be higher than 100, but the maximum score that's reported by many assays is 100, though I can actually tell you I did have one patient that had 150. So it depends on which assay, how it's being reported by your lab. And I have the CPS thresholds that are listed there, and they will be discussed in the specific tumor modules as well. So atezolizumab is a little bit different. So atezolizumab looks at the percent IC and the percent TC. So the percent IC is the proportion of tumor area accompanied by or occupied by PD-L1 expressing tumor infiltrating immune cells of any intensity. And then the percent TC is the percentage of PD-L1 expressing cells of any intensity. Originally, the percent IC was what was used as the companion diagnostic in the case of metastatic triple-negative breast cancer, as you see here, and bladder cancer. However, the first-line non-small cell lung cancer approval of atezolizumab includes both a TC cutoff or an IC cutoff. And you can see an example of how this may be reported from a lab where you see the IC score and then the TC score both being reported. So new to this list is Nivolumab. So Nivolumab now has an companion diagnostic approval for a PD-L1 TPS of at least 1% if used for first-line therapy in combination with ipilimumab for non-small cell lung cancer that does not have EGFR or ALK genomic alterations. So the Nivolumab PD-L1 TPS score is very similar to the pembrolizumab TPS score. And it measures the percent of evaluable tumor cells showing partial or complete membrane staining of any intensity. And again, I refer you to the handout that gives a more complete list, and you will also, it also kind of sets you up nicely for where you will also see this information discussed in each of the individual modules. So we now have our fourth case. This is a 55-year-old female with metastatic endometrioid adenocarcinoma of the endometrium who was initially treated with carboplatin and paclitaxel, followed by a clinical trial with a novel PI3K inhibitor. She developed a new lower quadrant mass that was biopsied and confirmed to be recurrent disease, and this new mass was sent for NGS testing that showed she has a microsatellite status MSI high tumor with a high tumor mutation burden of 105 mutations per megabase. So which of the following treatments would you recommend? Nivolumab, Nivolumab and ipilimumab, pembrolizumab, or atezolizumab? So pembrolizumab is currently the only agent that is approved independent of histology. Nivolumab and ipilimumab is approved for colorectal cancer specifically, and we'll talk about that. So we're going to finish up by talking about the drugs that are approved independent of tumor type, and you will continue to see them mentioned throughout the different modules going forward. So we have pembrolizumab, larotrectinib, and entrectinib that we will talk about with their respective biomarkers. So starting with DNA mismatch repair, DNA mismatch repair enzymes are involved in correcting errors that occur during normal DNA replication. And inactivation of these enzymes result in more errors occurring in the development of microsatellite fragments. So you can determine microsatellite status either by looking at the mismatch repair status, utilizing immunohistochemistry to assess the expression of MLH1, MSH2, MSH6, and PMS2 that are involved in DNA mismatch repair. If all 4 genes are normally expressed, this would be a proficient mismatch repair. And if you have the loss of expression of 1 or more, then this is considered defective or dysfunctional mismatch repair. Now, microsatellite status, microsatellite instability is indicative of a hypermutated phenotype in the tumor and consists of insertions or deletion alterations that stretch in stretches of short tandem DNA repeats called microsatellites. So in addition to a high number of gene mutations throughout the DNA, the tumor DNA, which makes sense because if you don't have those mismatch repair enzymes being able to fix DNA, you're going to have more tumor mutations being formed. MSI testing is typically performed via genetic analysis and will be reported as either a microsatellite stable tumor. Some assays will report a microsatellite low tumor based on the specifics of the assay. Or you would see if there's a high level of microsatellite instability, it will be reported as an MSI high. Patients with dysfunctional mismatch repair identified by immunohistochemistry are biologically, for the large part, the same as those with a high microsatellite status. There is some ongoing research that this may evolve a better understanding in the future, but for the purposes of the drug approvals, you can look at either an IHC test or the NGS test. So the presence of dysfunctional mismatch repair, or MSI high, is most common in colorectal cancer and endometrial cancer, and it has been associated with response to immunotherapy. So pembrolizumab is approved for any solid tumor following prior therapy with no satisfactory alternatives that have a MSI high by NGS testing or mismatch repair deficient by IHC testing. And this approval is for both adult and pediatric patients. Pembrolizumab is now approved as first-line therapy for patients with MSI-high or dysfunctional mismatch repair colorectal cancer based on the Keynote 177 trial that was just recently, that was presented at ASCO in 2020 and just recently published in its final form in New England Journal of Medicine and will be discussed in more detail in the colorectal cancer in module. Nivolumab, with or without ipilimumab, is approved for adults or pediatric patients with unresectable or metastatic MSI-high or mismatch repair deficient colorectal cancer only following additional lines of therapy. So our second tissue agnostic biomarker is tumor mutation burden. Tumor mutation burden indicates the number of non-synonymous mutations reported per megabase. These mutations that are found in a tumor can create novel antigens called neoantigens that can then be recognized as foreign by the T cells. A higher number of mutations may increase the chance of a neoantigen developing, and then thus this can increase the chance of benefit from immunotherapy. Association between a higher tumor mutation burden and improved outcomes have been previously reported across numerous histologies, though there are stronger correlations that are seen with certain tumor types. So pembrolizumab was recently approved based on the Keynote 158 study that looked at a total of 108 patients across different tumor histologies that were evaluable for tumor mutation burden. So they defined tumor mutation burden as greater than or equal to 10 mutations per megabase by the Foundation CDX panel. So this was a tumor-based panel. And the overall response rate was 29% for all of the high tumor mutation burden patients, and 6% for those with lower or who did not have high tumor mutation burden. So ultimately, pembrolizumab was granted accelerated approval for adult and pediatric patients with unresectable or metastatic tumor mutation burden of at least 10 mutations per megabase who have progressed on the prior treatment. I will note that the tumor types involved in this specific study were small cell lung cancer, cervical cancer, endometrial cancer, anal cancer, vulvar cancer, neuroendocrine cancer, salivary gland cancer, thyroid cancer, and mesothelioma. So it was a more limited group, and but the approval did include all tumor types. So we have our final case here. This is a 38-year-old male with metastatic soft tissue sarcoma who has progressed on 3 prior lines of therapy. A cell-free DNA test is performed and revealed a NTRK1 activating fusion. And the medical team is considering starting therapy with larotrectinib. So is larotrectinib appropriate? Yes. It is appropriate. No, it is only approved for pediatric sarcomas. No, larotrectinib is only approved for activating NTRK1 missense mutations. Or no, because this was a cell-free DNA assay rather than a tumor-based test. So in this case, larotrectinib is appropriate. It is approved for both the adult and pediatric patients with activating NTRK fusions. Clinically relevant NTRK missense mutations are most commonly seen as acquired resistance, and the approval is specifically for an activating fusion. So we'll finish up with talking about our new NTRK inhibitors, which is our third tissue agnostic biomarker. Larotrectinib was the first tyrosine kinase inhibitor that was approved for a tissue agnostic indication in both pediatric and adult patients for patients whose tumors harbor a fusion, an activating fusion in NTRK1, NTRK2, or NTRK3. And I have the most common tumor types. They're pretty rare, but you can see them in salivary gland, soft tissue sarcomas, infantile fibrosarcomas, as well as thyroid tumors. The approval was based on a 55-patient study where there were 17 different solid tumors represented, and the overall response rate was 75% by independent review. After 1 year, 71% of the responses were ongoing, and 55% of patients were progression-free, with no patient discontinuing therapy due to adverse effects. And the long-term results of this study are ongoing for assessment. Our second NTRK inhibitor is entrectinib, and it has a very similar approval to larotrectinib. It is approved for solid tumors in both a pediatric and adult setting. For patients whose tumors harbor an activating fusion in NTRK1, NTRK2, or NTRK3. It also inhibits ROS1 and ALK and is also approved for ROS1 mutated non-small cell lung cancer as an additional option. So this was based on 4 different clinical trials that evaluated 54 patients with activating NTRK fusions. The overall response rate was 54% with a complete response rate of 7% and partial response rate of 50%. The median duration of response was 10 months and it was also very well tolerated. Both of these drugs were approved based on a accelerated approval, and so the ongoing longer-term studies are anxiously awaited to update these approvals and this our understanding of the long-term responses. And with that, I would like to conclude this presentation and thank you all very much for your attention.